My name is Jessica Hubbard, and I'm a manager for Community Education Department at MDA. We're thrilled to have you join us for MDA's virtual learning series on DMD. We look forward to seeing you on December 11th for the live Q&A session with all of the presenters from this series. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates and upcoming events. MDA would like to thank RegenXBio for supporting this virtual learning series. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, care, advocacy, and engagement. And since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. MDA funds projects throughout the drug development process, from early discovery through translational stages and infrastructure support for clinical trials. Our care centers are located at over 150 top medical institutions nationwide, and our advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, treatments, independent living, newborn screening, accessible air travel, and more. And finally, our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Now it is my pleasure to introduce today's speaker, Dr. Batley from UT Southwestern. Dr. Kaitlin Batley is a pediatric neuromuscular neurologist and director of the Pediatric Neuromuscular Program at UT Southwestern and Children's Health in Dallas, Texas. After completing child neurology residency and pediatric neuromuscular fellowship at UTSW, Dr. Batley then joined faculty as an assistant professor of pediatrics and neurology, also serving as the pediatric neuromuscular fellowship director. She oversees clinical operations and manages a multidisciplinary team to provide care to children affected by neuromuscular disorders and their families. Dr. Batley is also involved in research, participating in over 20 clinical trials and natural history studies. Thank you, Dr. Batley, for being here today, and I will now turn the time over to you.
Awesome. Thank you so much. I'm so excited to be here, and I'm just going to share my screen and we will get started. And I'm thrilled to be talking with you all about some of the new treatment considerations in Duchenne muscular dystrophy. So a couple of disclosures for some different companies that I've worked with on advisory boards or spoken for listed here. And then today we will be reviewing the approved therapies for DMD, talking a little bit about the differences between the therapies and who they might be applicable for, and then some of the upcoming therapies in the research pipeline. So first, just a brief overview of Duchenne muscular dystrophy, or DMD. So we know that this is a severe neurodegenerative disease that causes progressive muscle weakness and ultimately affects the heart and lungs as well. It is a genetic disorder with X-linked inheritance affecting about 1 in 3,500 to 5,000 boys. This disorder affects the DMD gene, and a variant in this gene causes disruption and a lack of functional dystrophin production. And without this protein, which is very important for linking the cytoskeleton network to the transmembrane components of the muscle, muscles are much more at risk for disruption and ultimately undergo destruction and necrosis, which leads to progressive muscle weakness. So without this properly functioning protein called dystrophin, there is injury to muscle fibers, chronic inflammation of the muscles, and impaired ability for the muscles to regenerate or heal themselves. And ultimately, the muscles are replaced with fat and kind of fibrous scar tissue. And this is what causes the muscle weakness. So we're fortunate to be in an era where we have several different options for treatment strategies. And so we're going to go over some of those today. And we'll first begin with discussion of corticosteroids, which have been the most long-standing therapy that we have for DMD and still remain kind of the backbone of treatment. So there are a lot of hypothesized thoughts for how corticosteroids are useful in DMD. A lot of it seems to be around the anti-inflammatory nature of these medications to help kind of decrease that chronic inflammatory response that's seen in the muscles of DMD. We also think that it helps to kind of stabilize the muscle membrane and improve the muscle's ability to repair itself or regenerate. There have been many, many studies that have looked at the potential benefits of steroids in DMD. We know that steroids improve muscle strength over the short term, and in that way we see our standardized test numbers increase. We know that that can help us to increase our kind of lung function testing and some of the different measurements that we look at there, and delays the onset of decline of these of the muscle function in our respiratory system. Also reduces the risk of severe scoliosis, which then decreases the need for potential scoliosis surgery. And then, of course, importantly, prolongs the time to loss of ambulation by about 2 years. And there's also suggested benefit for cardiac function as well. But the downside to steroids is that we know that they often come with potential side effects. These are not experienced by all patients, but they are potential. And so one of the biggest things that I think we see is weight gain. And then we can also see some behavioral changes, usually manifesting as irritability, sometimes anger or aggression that can be difficult to manage. We can see a Cushingoid appearance to the face, whereby the cheeks kind of get a little bit more round. And then with more long-term use, we can see things like a decrease in the bone density or thickness of the bones, which then can cause increased susceptibility or easier time to fracture, as well as cataracts or clouding of the eyes, increased blood pressure, increased blood sugar, adrenal suppression, and impaired immunity as well. So we now have 3 different steroid options, and so we will focus mostly on the most newly approved therapy, but prednisone, which has been used for the longest amount of time, followed by deflazacort or Emflaza, which is an FDA-approved corticosteroid for Duchenne, and then we'll talk about vamorolone or Agamree. So this is being called kind of a dissociative steroid, and it is a similar chemical structure to the steroids that we know, prednisolone and deflazacort. You can see on the slide outlined with the red and the blue boxes in the chemical structure of these molecules that there is a slight difference. And this little difference allows it to affect the different receptors slightly differently. So it still retains that good anti-inflammatory benefit by affecting the glucocorticoid receptors, which is the main kind of goal with using steroids in DMD. But then it acts differently at another kind of receptor called the mineralocorticoid receptor, and it acts as an antagonist instead, which is actually similar to some of the medications that we often use in DMD cardiomyopathy, one called eplerenone, which is the other chemical structure you can see on this slide. And so that small difference is proposed to cause a difference in the side effect profile. So first and foremost, in the studies, they looked at whether vamorolone was at least as efficacious as prednisone, which is what they compared it to. And initially, the comparison was done to placebo. They used young boys who were not yet on steroids. And you can see that the dashed red line is the placebo group, and then vamorolone is the blue line. And you can see that in all of the modalities that were assessed, that there really seemed to be similar function across the board as compared to using prednisone in these patients. And so the kind of conclusions of the study were that vamorolone was at least as efficacious at maintaining motor function as prednisone. And then some of the other conclusions of the study looked at the adverse event profile. And so they found that there seemed to be a reduction in the different behavior issues that can be seen after starting steroids when patients were transitioned from prednisone to vamorolone. They also saw, as you can see in these pictures here, an increase in the height velocity. So it seemed that the kind of reduction in height seen by prednisone was not an issue with vamorolone. And then there also was a reduction in different markers that they look at in the blood that tell us about bone turnover. And so that seemed to be an improvement in bone health seen with vamorolone compared to prednisone. And then in this chart here in the middle, you can see VF stands for vertebral fractures. They looked at the incidence of vertebral fractures in different groups comparing to natural history studies. And in deflazacort and prednisone, given daily, there were a high risk of vertebral fractures, and this was much lower in the vamorolone treated group. There were, unfortunately, similar increases in BMI or body mass index. So that's kind of a function of weight gain. So it seemed like vamorolone at the highest recommended dose still seemed to cause that weight gain. And then, of course, adrenal suppression as well was still similar to prednisone. And so next we'll move on to some of the novel therapeutics, non-corticosteroid options. The most newly approved medication is one called givinostat or Duvazat. And this is called an HDAC inhibitor or a histone deacetylase inhibitor. And we know that as part of the pathophysiology of DMD, there is an increase in this HDAC activity as a function of the disease itself. And so this medication proposes to kind of decrease that activity and hopefully kind of counteract this, the consequences of having a lack of dystrophin. And in phase 2 trial done early on, they found that there was an increase in actual muscle tissue in the boys who were treated with this medication, which leads to a proposed improvement in muscle regeneration. And they also found that there was less of that fibrosis and necrosis, so that breakdown of the muscle itself, so perhaps slowing the degeneration of the muscle. So then they move forward into the next phase, their phase 3 placebo-controlled trial of givinostat, and they used several different kind of standardized testing scores to look at improvements in motor function. And you can see here they're listed 4-step climb, the North Star ambulatory assessment, and so on. And it seemed to all favor an improvement in these function tests with treatment with givinostat. The ones that were statistically significant were the 4-stair climb and the NSAA, but everything seemed to favor improvement with this treatment. They also looked at MRI or imaging studies of the muscles, and they found that there was about a 30% decrease in the infiltration of fat into the muscles, and so thereby kind of having more typical muscle structure when they looked at the images. And so that also seemed to be a benefit of this medication. So this medicine was approved by the FDA in March of 2024 for boys ages 6 and up. And this is an oral medication, which is really nice because some of the medicines that we have to use are given in different modalities, such as IV. And so this is exciting to have an oral treatment. And it's also not specific to any genetic variant. So there are no kind of qualifications on who can receive it based on genes alone. And it also does not comment on ambulatory status is in the approval as well. There are some potential side effects. It can affect the platelets, which are the clotting factors of the blood. It can also affect the triglycerides in the blood and the heart rhythm. And so there is a monitoring protocol after starting the medication to look for all of these side effects as well. And so we'll move on to discuss briefly some of the updates in exon skipping. We won't go back through some of the more well-established information, but we'll talk a little bit about this kind of therapy. So the currently approved exon skipping therapies are what we call PMOs, and they are designed to help remove the exon that's disrupting the reading frame of the gene, and then kind of link together the functional pieces to create a dystrophin protein that is still missing kind of the internal portion, but is at least making a little bit more of a functional protein. So you can see here in the slide that in a kind of healthy individual where the dystrophin is not affected, you can see how each of the boxes kind of line up together and fit together perfectly, and then create this dystrophin protein that has all of the pieces that it needs. In a patient with DMD, you can see that because there is a missing piece of information, the boxes no longer line up the way that they're supposed to, and that causes a disruption. And so the body is able to kind of read along that, and then it gets to the disrupted portion and is no longer able to move forward anymore, and that causes that lack of functional dystrophin protein. In a patient who is then treated with an exon skipping therapy, the medicine itself is actually able to take out one of the other boxes to then allow all of the remaining boxes to kind of line up again together, thereby allowing the body to kind of read through there and make a more functional protein, although it still is not the typical protein, and so it's kind of a shortened but more beneficial protein. So we have 4 different therapies that are currently FDA approved for individuals who are amenable to skipping of exon 45, 51, and then 53. And you can see that this is applicable to 9%, 14%, and 8% of boys in each group. And so this is still overall a relatively small number of individuals. And so not applicable to everyone, which is the main downside of these therapies. These were approved by the FDA on what we call an accelerated approval, using the increase in the amount of dystrophin protein seen in biopsies of the muscles under the microscope from prior to treatment and then later on time point in the study. And so based on this increase in dystrophin, it was proposed that this should lead to an increase in muscle strength and function, and thereby they were approved. But we do need still to see some additional data to allow this approval to continue and continue using these medications. So these medications are administered once a week, and they do require intravenous infusion. So either an IV has to be placed, or some boys will have a port to allow for this weekly administration. And that's kind of the most difficult thing about these medicines. However, they do seem to have a very good safety profile and appear to really slow progression of disease, although we still are looking for more data to kind of help us understand this a little bit better. And so with that, we've got a little bit of an update on our exon skipping therapies. So presented last year at the MDA conference, we saw some of long-term outcomes of golodirsen. And first and foremost, we saw that safety was still maintained throughout this time period. And we were able to see a little bit longer term data and saw that loss of ambulation seemed to be delayed by about 2.4 years in patients who were treated with golodirsen compared to external control groups, and so natural history studies of what we know about disease progression. We also saw that there was slowed respiratory decline, and so instead of declining by 6.7% per year, the forced vital capacity, which is one of the lung function markers, declined by 2.9% per year. So about, half, which is excellent. And this was proposed to delay the need for respiratory support by about 5 years or so for cough assist, and then by about 7.5 years for nocturnal ventilation or that use of BiPAP overnight. And then there were some updates about eteplirsen, and this appeared to extend survival as well. This was actually the first PMO or first exon skipping therapy approved in 2016. And the survival was increased compared to a natural history cohort study of about 27 years up to 32 years. And they found that the longer that a patient was treated with eteplirsen, the longer the survival time was increased. So kind of more time on this medicine seemed to be more beneficial. And again, compared to natural history control studies. And so finally, we'll move on to our gene therapy updates. So first, we will talk about Elevidys, or delandistrogene moxeparvovec. And so this is a novel therapy that uses what we call a transgene, or a new kind of instruction manual for how to make the DMD protein. And they package it inside of a viral vector. And this viral vector in particular that's used is the AAV-RH74 viral vector. And the transgene that's put inside of this viral vector is then designed to deliver to all of the different components of the body. And so this gene transfer therapy is administered one time, at least right now, through an IV. It does have the potential for serious adverse events. Most commonly, we see some nausea and vomiting or some fever following the infusion, but there is the potential for acute liver injury, injury to the heart muscle, another phenomenon called thrombotic microangiopathy, whereby the blood vessels have kind of this collection of platelets and other clotting factors that can cause little blood clots that can go to different parts of the body. And then also an immune-mediated myositis, whereby the body kind of gets confused and attacks that new dystrophin protein in the muscles. And then, of course, because of the newness of the therapy, there is the potential for unknown adverse events as well that we just haven't encountered yet. And so because of this, there's a very kind of intense and careful monitoring process whereby boys are getting at least weekly, sometimes more frequent, blood testing or laboratory monitoring for the first 3 months after dosing, but sometimes extending longer if there were any complications. And then boys take even higher dose prednisone than what they might have been on just for DMD alone to kind of help decrease the inflammation and decrease these side effects as well. So the pivotal trial that was done prior to approval of this medication was called EMBARK, and this was a placebo-controlled trial looking at safety and efficacy in boys ages 4 to 7 years old. And so there were 2 parts of the study. In the first part, half of the boys received the investigational drug, and then half received a placebo infusion. And then 52 weeks later, they kind of switched, and the boys who received the medication originally received placebo, and the boys who received placebo received the gene therapy medication, and then they were monitored throughout all of these time periods. So the primary endpoint, or kind of the number one goal of the study, looked at a functional test called the North Star Ambulatory Assessment, or NSAA. And this study did not find a statistically significant difference between the boys who were treated and the boys who received placebo at 52 weeks in this North Star test. But there are several thoughts about why that might be. First is that the study itself overall is relatively short, even though a year can be a long time. Sometimes it takes longer than that to really see the difference, especially in the age group of these boys, with some of the younger boys still seeing developmental improvements just with age, and may not have reached kind of the decline phase of the illness where you would expect them to begin having, onset of muscle weakness. And so in that way, it might be just have too short of a time period that they were watching. And then also, we see now kind of in hindsight that maybe the North Star wasn't sensitive enough to pick up some of these differences. The North Star looks at different functional abilities, such as, being able to stand on one leg, jumping, and getting up from the ground. And we'll use that as an example. So the scores are either a 0 in that a boy cannot perform the task at all, a 1 in that they perform it but need some kind of modification, or 2, they perform it just typically well. And so you can use the example of standing up from the ground. So the score of 1 means that you needed a little assistance. So that could be evidenced by a boy maybe putting one hand down on his leg to help just give him a little push and popping right up from that. But a 1 is also a boy maybe who had a lot more trouble and had to really kind of climb up his legs in order to stand up, that kind of typical Gower maneuver that is often talked about in DMD. And so both of those are a score of 1, but you can see that they really look very different. And so it's possible that because of this, we just weren't able to see the benefits. And so thankfully there were other endpoints that were looked at. And some of those are listed here. We've got the time to rise. We've got the 10-minute walk run, a measure of stride velocity, time to climb 4 stairs. And so these were all assessed as well as kind of these secondary and exploratory outcomes. And so all of these seem to favor an improvement with treatment with Elevidys. And so because of that, and because of the fact that there were no new safety issues, and they found that all of the adverse events that were encountered were manageable, they kind of concluded that Elevidys did seem to improve disease trajectory. Of course, because the transgene that is packaged inside of this viral vector is still a shortened form of dystrophin or a microdystrophin, there is still an understanding that this kind of treatment would not be a cure because it's not providing a natural dystrophin protein. It's a shortened form, but it did seem to be that there was an improvement seen with this medication. And so because of that, it was FDA approved. And then this year we saw an expansion of the label for approval. And so now candidates for gene therapy are required to be at least 4 years of age and older. They cannot have antibodies to that viral vector that this medicine is packed into. And so all boys before going through this process are tested to see if they have those pre-existing immune fighter cells to this medication. Because if they do, and they were administered this medicine, their body would immediately recognize it as foreign and begin to kind of attack it. And so then it would not be efficacious. There is also a requirement that, we check our baseline labs to make sure that there is normal liver function, platelet counts, and then troponin level, which is a marker of the heart. And so just a little note on that, boys with DMD will have an elevated liver function test called the AST and the ALT. And the reason those are elevated is because those are also markers of muscle function. And so just like the CK or creatine kinase is elevated, so are these liver function tests. And so the boys will have, that as a baseline elevation, and we understand that as a function of the disease. And so we check other levels of the liver as well to make sure that we don't see any signs of any issues. We do know that this medicine is contraindicated in any boys who have a deletion in exon 8 or 9 of the DMD gene. And that's because in individuals who have deletions in those regions, there were adverse events that were seen in several of the clinical trials. And so right now, for safety reasons, we're not administering to boys who have that type of genetics. And so we also have an understanding of the types of approvals that this medication has received. So in ambulatory patients or boys who are still walking, the FDA has given a traditional approval. And then in boys who are no longer walking, they have given what we call an accelerated approval. And so what this means is that the FDA approved the medication for use in that non-ambulatory population based on some of the early markers that it could be beneficial, which is the increase in dystrophin seen in the muscles. But still more data is needed to kind of confirm this and to continue this approval into the future. And so further studies are ongoing to help clarify this as well. And so quickly, we'll touch on some of the available clinical trials that could potentially be options for some of your family members. So for exon skipping, there are additional trials that are looking at exon skipping to increase this technology to different types of genetic variants. And so there is a trial by NS Pharma that is using a medication to skip exon 44. And this is a once weekly infusion. And they're looking for boys ages 4 to 14 years old for this trial. And everything that I'm going to talk about is available on clinicaltrials.gov, which if you go to that website and type in these keywords, you can find the trials as well as who to contact if you're potentially interested in participating and to see whether your loved one might be a good candidate. There is also another exon skipping for exon 51 amenable patients, and this is a therapy that's given less frequently than the current FDA-approved therapies. And so depending on which arm of the trial, could be given every 4 or 8 weeks, still through IV. And this is by Dyne Therapeutics. And then another exon 44 skipping trial through Avidity Biosciences that is also looking to kind of extend out the frequency of infusion, so every 6 to 8 weeks for this trial. And then there are also ongoing trials looking at gene therapy as well. So RegionX Bio is currently recruiting for their trial, and they are looking for boys age 1 to 11 years old who have genetic variants in exons 18 and above. And this uses a different viral vector from the currently approved therapy using an AAV8 viral vector. There is also a study being done to understand whether boys who have elevated AAVrh74 antibodies or immune fighter cells at baseline could be treated. And so this is a study by Sarepta using the currently approved Elevidys and some different techniques to try to treat boys who have positive antibodies. And then there are clinical trials ongoing for therapies with other mechanisms of action as well. And so one of these is by Edgewise Therapeutics, and this is an oral medication that is thought to potentially protect the muscle from breakdown. And they're looking for boys age 4 to 9 years old and no specific genetic mutations. And then Edgewise is also looking at the use of this kind of medication in boys who had already been treated with gene therapy as kind of an add-on afterwards to see if that could be beneficial as well. And then there is also a study using a monoclonal antibody that is thought to both kind of improve bone fragility and increase muscle function, and that's by Hoffman-LaRoche. And this is a subcutaneous injection, so goes into the skin and into the subcutaneous tissue. And they're looking for boys aged 8 to 15 years old. And there's also an open study looking at the use of corticosteroids in younger boys, ages 1 month to 30 months old, and to see if using corticosteroids in these younger patients could be potentially beneficial at, slowing disease progression, especially to, get them to an age where maybe they might be able to use different kinds of therapies. And so to protect the muscles during that time to see if this is beneficial. And this will use prednisolone or that oral steroid at a dose of 5 milligrams per kilogram of body weight 1 time a week. So not the daily steroids that we often use in older boys, but just 1 time a week. And then there is an ongoing study by Capricor looking at an IV infusion of cardiosphere-derived cells. And this is a study called HOPE-3 in boys who are 10 and older, both ambulatory and non-ambulatory. And so, as you can see, this is a really exciting era of medicine and hopefully a time where we are going to see just remarkable changes in what we know about Duchenne muscular dystrophy, with the hopes that, we'll be able to use combination therapy with all of these different kinds of medications being studied and approved, that this will lead to personalized precision care whereby each boy is getting exactly the right treatment for them. And in doing so, improving longevity and quality of life and just really changing what we know about DMD. And this is just an exciting time, and I'm glad to be here and working with such an amazing group of people. So thank you all for everything that you do, and I look forward to speaking with you at the live Q&A.
Thank you so much, Dr. Batley.
Thank you. I appreciate you having me.
Yeah, let me get my bearings here to share my screen again. But yes, thank you so much for that wonderful information. I'm excited for our community members to get to join us on December 11th for any questions they may have following your presentation. I would also like to invite our community, if you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who's diagnosed, we encourage you to engage with us at mda.org, or you can scan this QR code on the screen to join the MDA community. Joining is always free, and we'll keep you up to date on the latest research and educational programs and supports. Again, MDA would like to thank REGENXBIO for supporting this virtual learning series. And we look forward again to seeing you on December 11th for our live Q&A session with all of our presenters. That will be at 4 o'clock Eastern. And then if you have any questions or need more information, please contact the MDA Resource Center at 1-833-ASK-MDA1 or at resourcecenter@mdausa.org. Thank you again, Dr. Batley, and this concludes our recording for today.